And so far it's been really great, and I hope that we also can keep up with the standard. So, surveillance encompasses a range of activities, from collecting the data through analysis to generating and disseminating the results, which hopefully will be used by someone for some reason. Now, people who work with surveillance tend to focus on that first bit because that is the easiest part, in particular these days with so many data sources being in electronic format. And here I must also include myself to those people. But as a matter of fact, if we don't use the data that we collect, then the whole action is pointless. So, within the field of public health, we often talk about data for action, thus emphasizing that the data that we collect are meant for, well, action. Now, these actions, they can vary depending on what public health issue that we are investigating. The actions will also vary depending on the function that the organization collecting the data has. So examples of actions that can be taken by a public health agency, that is to give recommendations to the healthcare sector, to inform decision makers, to investigate outbreaks, and to make epidemiological analysis and reports. So today I will talk about 3 different surveillance activities in which I've been involved, and we will really have tried to ensure that the data that we collect are used in a way to inform and guide those who are responsible for the infection prevention and control. So I will talk about how we use queries that are submitted to a national medical website to inform our epidemiologists. I will talk about mobile reporting of positive malaria cases in South Africa. And I will very briefly talk about a mass gathering in India at the very end. So, let's get started. So the first activity takes place in Sweden, which is, just for information, situated in the north of Europe. We have a population of almost 10 million people, and it's a highly urbanized country, so there are almost 40% of the population that live in the 3 largest cities. And another piece of statistics that is relevant for what I will just talk about is that more than 90% of those who are between 16 and 75 years old have access to internet at home. So here you can see a screenshot of a medical website called 1177.se. This website is owned by the healthcare sector in Sweden, and it contains information on healthcare services, on diseases, and also give self-help advice. Now, as on most websites, the user has the possibility to search for information, and everything that's submitted to the search engine connected to this website is logged. And it is these logs that we use for our surveillance purposes. And here I would also like to mention that the logs that we work with are anonymous. So in 2014, there were about 9.5 million queries submitted to the search engine on this website. So just to give you a rough overview of how the information flows. So a user will state 1 or more words reflecting his or her information needs. These are logged, and then once every day they're automatically transferred to the public health agency. Then automated and disease-specific analysis are run, and the result, which is often in the form of a graph, will be automatically emailed to the epidemiologist in charge of the disease in question. Now, in some cases, we will also publish this information online, for example, in a weekly newsletter, and this is the only stage that is manually, where there's a human actually coming in, because we don't want to disseminate information that is fully automatic to a wide audience. So one of the things that we've looked at is influenza. And here we have included 20 query types, some of which are overlapping. So we have the term influenza, both on its own in various constellations such as compounds. We also have included 7 symptoms to reflect influenza-like illness. And we also have queries in the model that might interfere with the output, such as influenza vaccination and stomach flu. So, the resulting model is that given the number of queries for each of these 20 types, we will have an estimation of the proportion of persons with influenza-like illness. So in that respect, this model is similar to Google Flu Trends, or why not the other way around? And this is what a graph looks like. This particular graph was generated 2 days ago on Monday morning. And as often with influenza, we have aggregated the data by week. That's on the x-axis. And the current season is in red, and we also have included 2 previous influenza seasons in this particular graph. And then on the y-axis, we have the estimated number of persons with influenza-like illness per 100,000 people, which is the ILI measure that we use in the country. And as you can see, the influenza is now on the decline. It's been a fairly tough season, and this is something that we also see in our other systems. Another thing that we've been working with is the winter vomiting disease, and that is caused by the norovirus. Now, for most people, the norovirus will be nothing but a nuisance, but for weak persons, this might be lethal. And it also causes disruption in the healthcare, for example, with closed wards and postponed surgeries. This survey has been included in our written survey since 2010. And I want to show you a graph where we have in red, we have queries on the word vomiting, and in green we have queries on the word winter vomiting disease. And this graph includes data from July 2006 up until July 2013. And again, the data are aggregated by week. Then we have in blue the number of positive norovirus samples as reported voluntarily by our laboratories. And what is interesting in this graph is that we can see that the green and the red lines, that is the queries, they are always ahead of the blue line, that is the laboratory reporting. So what we assume then is that the winter vomiting disease, the spread of the norovirus, would start in society as reflected by the queries and then spread into the healthcare sector, because that is where people are sampled. No one in society is normally sampled for norovirus, but in a healthcare situation, if someone shows typical symptoms, then he or she must be isolated if it's norovirus. So the difference of the 7 seasons that we investigated in 2013 was on average 2 to 3 weeks. So this shift in the curves that we could see. So at the same time when we did this investigation, we also sent a questionnaire to the infection control teams at the hospitals in the country. And what we found was that most of the infection control teams, they wouldn't put any firmer hygiene routines in place unless there'd already been an outbreak, or they would do that at a particular date regardless of what reality would look like, which means that you risk that compliance will decline already before you've had any spread of the virus. So by defining a statistical threshold for the queries, we're able to issue an early warning to the healthcare sector and notifying them that it's fairly likely that within 2 or 3 weeks you will have a spread in the hospital. So I will now, before leaving this part of the presentation, go through the pros and the cons with using this kind of data for surveillance. And I will actually start with the cons so that I can end with the pros. So one thing is that we don't have any demographic information provided of those who search for information, and that might seem to be a drawback, but actually I think it's an advantage, because I don't think that it would be decent if a public health institute had access to the information that people are looking for when it comes to health. So the geographical information is very limited, while we aggregate the data on a national level. And we also know that the users aren't representative of the Swedish population. So for example, there are more women looking for information, and also the elderly elderly are underrepresented. And the last thing is that we actually don't know if those who are looking for information are ill or not. What we have seen, though, is that it's an advantage to work with a medical website. So, to give you one concrete example, the strings containing the word vomiting on Google, the third most common one would be vomiting dog. And that is a string that is not found on, well, in principle, I would say it's occurred a couple of times among all these millions of queries. So that is a clear advantage. So the data that we get are nearly real time, because we get a lot from the previous day. Also, we know that the data will reflect a point of time close to onset, and that is, of course, provided that the people who are looking for information are ill. Also, the data source come in a form that makes it easy to set up automatics. I feel like I want to dance. And I will pretend as if nothing has happened. And finally, a system that is based on web queries can easily be adapted to various diseases or other public health issues, because we have all the information that one potentially could want to look for. And this last thing is something that I never thought about when I started to work with this data source, and that is that it can help the agency to get a logical message through. So again, to give one concrete example, that for some reason journalists, they find this combination of web queries and vomiting very appealing. So every year when we issue this early warning after spread in society, they will write tons of articles on that, and that gives us a brilliant opportunity to promote some good hand hygiene to the public. So the next part is work that I've done in collaboration with Karolinska Institute at the National Institute for Communicable Diseases in South Africa. So first of all, I will give you an overview of how the malaria reporting works in South Africa, because that's the diagnosis we've been working with. So a patient will typically be diagnosed at the primary healthcare level through a rapid test. And the clinic will fill out a form, which is a particular form for the malaria. And South Africa is currently in the elimination phase of malaria, and for that reason, the government set up a number of indicators. So, for example, a positive case, a new positive case, should be reported to the local authorities within 24 hours. And this is done by someone who works, a designated person who's in a so-called malaria team that will come and pick up the form at the clinic. So the next step is case investigation in order to try to find secondary cases, and that should be done within 48 hours. And the last thing is that the provincial authorities should be notified within 72 hours. Now, this would be all fine if this was the reality. However, late reporting is very common. And one reason for that is that the malaria team has to travel very far on roads that are often in very bad condition. So rather than coming every day, which they should, they might come once a week to the clinics. So what we did is that we used a smartphone for submitting patient-level data on each positive malaria case, just as they are within the current malaria program. And these reports were submitted to those who currently obtain the data. And in addition, we also sent an SMS notification to the malaria team coordinator in the district, so that they would know that now there's a new case that's been reported, please go and pick up the form. And we performed this study for 8 months, for one malaria season. So we worked in a very rural area in South Africa, and it's got irregular access to telephones and fax lines, minimal access to computers and internet, and the cell phone coverage is very good though. So we did a thorough evaluation. The technical evaluation included simplicity, flexibility, and usability. We also talked to the users about acceptability, we investigated the timeliness of the reporting. So the timeliness is the only thing I will go through very quickly here. So during that period, with the 3 clinics that we worked with, we had 24 positive cases reported. And out of these, we could include 23 in evaluation. So what we saw that with the smartphone, the complete case information was entered into the central information system 2 to 3 weeks earlier compared to other clinics in the area. The magic bullet, though, turned out to be the SMS, because with this feature, 75% were notified to the local authorities within 24 hours, which is the indicator set. And if looking at the time between diagnosis and follow-up, which is really the interesting measure here, because that's when you have this action, that the season before we were there, you had 5% from the 3 study clinics that were followed up within 48 hours, when with the SMS we had 65%. And when validating these figures with the clinics in the area with the same case investigator but without the SMS reporting, there was only a tiny improvement between the 2 seasons. So what we saw was that in South Africa, reporting by smartphone is technically feasible and acceptable, and even someone who's never used a computer before can in a very short time learn how to use such a device for surveillance reporting. And also we would recommend to the malaria elimination strategy to include this kind of SMS feature, as that would support the aim of having no local transmissions by 2018. So this last part is on surveillance during mass gathering in India. So the 3 things I'm talking about today, they are different kinds. So the first piece of work, the web queries, that is research that has been incorporated into the routine surveillance of a public health institute. And the second part, the malaria reporting, that is a proof of concept which we hope can be adapted by the policymakers. And this third part is actually work that hasn't been done yet. So. And already yesterday we heard about Kumela, which is a reoccurring religious mass gathering. Well, it's not intended to be a mass gathering, but that's sort of what it becomes. And it's held every 3rd year in 4 different places in India. And in 2016, it will be held in the city of Ujjain, which is a fairly small city in the state of Madhya Pradesh, which is found in the center of India. So for a period of about 2 months, more than 30 million people are estimated to come to the city of Ujjain for ceremonial dipping in the river Shipra. Now, together with Indian colleagues, we plan to set up some kind of mobile reporting for surveying infectious disease symptoms. And we want to do that by conducting 100,000 interviews per day for a period of 3 months in strategically selected places. So a bit before the main festival and a bit after. And the aim with this reporting would be to keep the local authorities informed. And the aim also of the surveillance would be twofold. So one would be to be able to look for outbreaks, and the second, and perhaps even more importantly, would be reassurance, that is, so that the local authorities can say with certainty that there are no outbreaks that we don't know of. So together with Karolinska Institute, we have a long-term collaboration with India and with researchers that happen to be based in this city where the festival will take place. We also have a great team of data collectors, and we have experience with collecting surveillance data on mobile phones in the year before. I would, however, be more than happy to talk to any of you who might have some ideas on the study setup. So, to summarize. So I presented 3 different surveillance activities where we really try to ensure that the data we collect are used in a way to inform and guide those who are responsible for infection prevention and control. I've talked about how we use queries that are submitted to a national medical website. And I've talked about mobile reporting of positive malaria cases in South Africa. And thirdly, I've introduced Kumela, where 30 million people will come and bathe in one single river. So, thank you very much. And to conclude, I would just like to say that collecting the data is not the challenge nowadays. It's what we do with the data that matters.